Baki, are we expecting anyone else? Any other residents? आपके fellow residents कहाँ
So
हैं?
Dr. Abhishri is going for ECT.
Okay.
And Dr. Anusha is on leave. She'll be coming.
Okay. And बाकी seniors batch को कोई नहीं है? हाँ? कहाँ पे हैं वो लोग?
Send the ward only.
Start कर दो.
Good morning, everyone. Today I'm presenting my journal club, and my moderator is Dr. Shobit Garg, sir. The title of my journal club is Randomized Controlled Trial of the Effect on Quality of Life of Second versus First Generation Antipsychotic Drugs in Schizophrenia, Cost Utility of the Latest Antipsychotic Drugs in Schizophrenia Study, CUTLAS 1. The sources Archives of General Psychiatry, year 2006, first received in February 24, 2005. Final revision was in February 17, 2006, and was accepted on February 23, 2006. This study was supported by Project Grant 96/19/06 from the Secretary of State for Health under the United Kingdom National Health Service Health Technology Assessment Program. Dr. Jones, Murray, and Lewis gratefully acknowledge research support from the Stanley Medical Research Institute. The following were the authors: Peter B. Jones, Thomas R. E. Barnes, Linda Davis, Graham Dunn, Helen Lloyd, Karen P. Hayhurst, Robin M. Murray, Alison Martin. So the antipsychotic drugs have been the mainstay of schizophrenia treatment for almost 50 years. Many people with schizophrenia receiving typical or first-generation antipsychotics have had a suboptimal outcome with symptomatic relapses and disabling adverse effects, particularly sedation and extrapyramidal symptoms. Atypical or second-generation antipsychotics were hailed as a major advance, principally because of their lower liability for extrapyramidal symptoms. The first atypical drug, clozapine, is the most efficacious of all antipsychotics, but is restricted to treatment-resistant schizophrenia because of the adverse effects. Two systematic reviews showed that the two groups of drugs are generally equivalent in terms of efficacy against positive symptoms, whereas another study found evidence of superiority for second-generation antipsychotics. Claims of superiority of second-generation antipsychotics in terms of the treatment of negative symptoms, cognitive enhancement, fewer extrapyramidal symptoms, and improved subjective experience and tolerability have led to a general shift away from the first-generation antipsychotics in the treatment of schizophrenia. Nevertheless, meta-analyses have raised questions about the size and significance of these effects. Like first-generation antipsychotics, second-generation antipsychotics, apart from clozapine, are usually grouped as a class in clinical guideline despite pharmacological heterogeneity. The second-generation antipsychotics are much more expensive. The trial concerned the relative clinical effectiveness of the two groups of drugs rather than the efficacy of individual drugs. The primary hypothesis was that the use of second-generation antipsychotics would be associated with a clinically significant improvement in quality of life across 1 year compared with the use of first-generation antipsychotics. Secondary questions concerned whether this improvement would be associated with fewer symptoms and adverse effects, improved patient satisfaction, and lower total healthcare costs. The objective of this study was to test the hypothesis that in people with schizophrenia requiring a change in treatment, second-generation antipsychotics other than clozapine are associated with improved quality of life across 1 year compared to the first-generation antipsychotics. Now we come to the methods, protocol, and rationale of the trial design. This pragmatic, multi-center, rater-blinder, randomized control trial was designed to test effectiveness in routine clinical practice. Trial entry was defined by the psychiatrist deciding to change drug management. Broad inclusion criteria reflected normal clinical practice, and there was non-intensive follow-up with one primary outcome. The trial included an economic component and was called the cost utility of the latest antipsychotic drugs in schizophrenia study, CUTLAS 1. Participants were randomized to receive either a first-generation antipsychotic or a second-generation antipsychotic. The first-generation antipsychotics that were used were chlorpromazine hydrochloride, flupentixol, haloperidol, loxapine, methotrexate, sulpiride, trifluperazine hydrochloride, zuclopentixol, and the depot preparations of fluphenazine deconate, flupentixol deconate, haloperidol deconate, pipothiazine palmitate, and zuclopentixol deconate. Thiaridazole hydrochloride and droperidol were also included initially but were withdrawn from licensed use during the trial. The second generation antipsychotics were risperidone, olanzapine, amisulpride, zotapine, and quetiapine fumarate. The responsible consultant psychiatrists, special physicians in secondary care, choose the individual drug in each class before randomization. 5 medical schools in England were recruited, covering 14 National Health Service trusts in northwestern England, Nottingham, Western London, Southeastern London, and Cambridge. The Northwest Multi-Center Research Ethics Committee granted the ethical approval. The inclusion criteria were DSM-4 diagnosis of schizophrenia, schizoaffective disorder, or delusional disorder, age group between 18 to 65 years, at least 1 month since the first onset of positive psychotic symptoms, and psychiatrists electing to change the current first generation or second generation antipsychotic treatment because of inadequate clinical response or intolerance. The exclusion criteria were substance misuse or a medical disorder considered clinically to be the major cause of positive psychotic symptoms and a history of neuroleptic malignancy. So the randomization assignment. Randomization to first or second generation antipsychotics was concealed by a remote telephone service undertaken after baseline assessment. After stratifying by treatment center, the method of allocation was randomized per muted blocks within strata. Participants were recruited over 30 months from July 12, 1999 to January 18, 2002. The psychiatrist initiated the first dose of randomized treatment as soon as possible and were urged to keep patients in their randomized treatment arm for a minimum of 12 weeks and preferably for 52 weeks. If a treatment change was required, the psychiatrist was instructed to initiate an alternative from the same class. Adjunctive medication was allowed, but antipsychotic polypharmacy was discouraged. Psychiatrists had access to a custom-made best prescribing handbook. So the outcome measures. Primary outcome was the total score of the quality of life scale, an instrument used widely in psychopharmacologic treatment trials for schizophrenia, assessed blindly at baseline and 12, 26, and 52 weeks. Secondary outcome measures. Secondary outcome measures were done by positive and negative syndrome scale score, Calgary depression scale score, participant attitudes and adherence rating using the drug attitude inventory, and a 7-point drug adherence scale, global assessment of functioning scale score, scores on adverse effects scales like Simpson-Angus extrapyramidal adverse effects rating scale to assess Parkinsonism, Barnes akathisia rating scale, abnormal involuntary movement scale for tardive dyskinesia, and antipsychotic non-neurological side effects rating scale. And participant satisfaction rated at 12 and 52 weeks regarding the new antipsychotic medication, mental health, and adverse effects. Inter-rater liability was assessed using 10 videotaped quality of life score and PANASYS interviews. An initial assessment of inter-rater reliability for 9 trained raters yielded an intra-class correlation coefficient of 0.91 for the quality of life score total score and 0.75 for the PANASYS total score. There were weekly discussions of ratings within medical centers, monthly inter-center video conferences, and face-to-face inter-center meetings every 3 months where fidelity was discussed. Masking to allocation and cost. The following measures were taken to maintain the blinding: isolation of the offices of the clinical assessors from the other team members, use of passwords for electronic data, encryption of email for randomization, restriction of discussions about patients within the research teams. Participants were reminded to avoid open discussion of treatment assignment. Follow-up assessments were performed, blinded to randomized allocation at 12, 26, and 52 weeks. Participants were deemed to be lost to follow-up only after a minimum of 4 failed visits. Cost information was collected about the use of all services, including hospital, inpatient, and outpatient services, primary and community care services, and prescribed medications. Direct costs were measured as resource use multiplied by the unit cost. The statistical analysis. First, a conventional intention to treat analysis was performed using ENCOA, but restricting the outcome to 12-week scores. Then, in a per protocol analysis, participants who switched from their allocated arm before the 12-week follow-up were dropped and ENCOA was repeated. Sample size and power, the principal outcome, quality of life scale, total score, was used to determine the sample size using 80% power, 95% confidence, and two-tailed assumptions. The target sample size for detecting a difference of 5 points was 110 patients in each of the two arms, requiring a total of 254 participants to account for the projected follow-up rate of 75%. Now the results. First of all, the participant flow, 275 patients were referred. Of these, 9, that is 3%, were ineligible, 1 was unable to give the consent, and 36 refused to give the consent. 2 psychiatrists each withdrew a referral. Thus, 227 patients referred by 73 psychiatrists were randomized. One protocol violation, patient randomized before the referring psychiatrist reformulated the diagnosis, was included in the final analysis in his or her randomized treatment arm. This was the progress of the randomized patients through the study. 227 were randomized, 118 in the first generation arm and 109 in second generation arm. After the 12-week follow-up in the first generation arm, 0 people died. 20 switched to the second generation antipsychotics. 102 at 12-week follow-up were there. 98 in arm end at week 12. In the 26-week follow-up, 3 patients died. 14 switched to the second generation antipsychotics. 95 at 26-week follow-up were there. 1 changed back to the first generation antipsychotics, and at the end of the 26th week, there were 82 in the first generation arm. Then in the 52-week follow-up, 0 patients died. 21 switched to the second generation. There were 3 deaths in each arm. In the first generation arm, 2 deaths were due to cardiac failure and 1 was considered to be suicide or accidental death. In the second generation arm, 2 deaths were also due to the cardiac failure and 1 to septicemia in a quadriplegic patient. 11 patients, that is 5%, were categorized as lost to follow-up at 1 year, and 22 withdrew from the study. Including deaths, withdrawals, and loss to follow-up, 39 patients dropped out of the trial. So this was the primary outcome, that is quality of life score scale in the first generation and second generation apps. And at baseline in first generation and second generation, the mean is 43.3 and 43.5 respectively. At 12-week, it was 49.2 for first generation and 46.6 for second generation. At 26-week, it was 49.2 for first generation and 50.4 for second. And at 52-week, it was 53.2 for first generation and 51.3 for second generation. So this was the primary intention to treat and secondary per protocol analysis of quality of life scale scores. And this was the result of the secondary outcome, that is the various scales like PANASS, global assessment of the functioning scale, and so the result of this pragmatic randomized trial refuted the hypothesis that the use of second generation antipsychotics is superior to the use of first generation antipsychotics in terms of quality of life at 1 year. Clinical superiority has been defined as a priori as a 5-point difference in the quality of life scale score. Statistical precision was limited, but the intention to treat analysis indicated that true effects may have been in the opposite direction for this primary outcome and for the main symptom assessments. The confidence intervals for this effect in the opposite direction were wide, including the possibility of a small benefit for second generation antipsychotics, but much smaller than hypothesized. Much evidence concerning the relative efficacy of first and second generation antipsychotics come from relatively short-term trials, dropout rates are high, and effects are assessed using symptom ratings rather than broader outcomes. It is reasonable to speculate that the superior tolerability and possible benefits in efficacy in these studies might translate into better treatment adherence, improved clinical effectiveness, and enhanced quality of life, but as yet few data support such a view. The doses of some second-generation antipsychotics have become higher in routine clinical practice than those used in the original pre-registration trials. These trials provide benchmark data on adverse effect burden, but this may represent an underestimate. Furthermore, a range of adverse effects of first and second-generation antipsychotics is emerging. Serious weight gain, diabetes mellitus, and hyperlipidemia may all adversely affect quality of life. The conclusion. Two recent systematic reviews provided evidence that some second-generation antipsychotics are more efficacious than others. So the comparison of the two groups of drugs may have masked the effects of individual drugs that have particular efficacy or tolerability, advantages or disadvantages for subgroups of patients or between individuals. Louis and colleagues use the same pragmatic design, intention to treat analysis, and primary outcome to demonstrate the superiority of clozapine over second-generation antipsychotics as a group in treatment-resistant schizophrenia, CATLAS-2. This suggests that the present trial was sensitive enough to show the effect we hypothesized had it been present. Although we note the considerable pharmacological heterogeneity within and between the first generation and second generation antipsychotic groups, we consider the comparison between groups to have been clinically useful. One observational study supports the result, but there have been few pragmatic long-term randomized studies of the clinical effectiveness of first generation versus second generation antipsychotics. Two such studies stand out. The first was in a study by Rozenek and colleagues. 309 patients were randomized to receive olanzapine and second-generation antipsychotic and the classic first-generation antipsychotic haloperidol with flexible dosing and the use of prophylactic anticholinergic drug. This double-blind comparison did not reveal any advantage at 1 year for olanzapine in treatment adherence, symptoms, extrapyramidal symptoms, or overall quality of life as measured using the quality of life scale. Benefits in terms of reduction in observed akathisia and improved cognition were weighed against the problems of weight gain and higher costs. Lieberman and colleagues reported an 18-month double-blinded trial in which 1,493 patients with chronic schizophrenia were randomized to receive olanzapine, quetiapine, risperidone, ziprasidone, or perfenazine, a low-potency first-generation antipsychotic. Despite circumventing the haloperidol comparator problem, most patients in each group discontinued the assigned treatment because of lack of effect or intolerability. Olanzapine treatment was associated with the lowest risk of discontinuation and a different adverse effect profile. The remaining second generation antipsychotics differed neither from each other in terms of effectiveness nor from perfenazine. In conclusion, there is no disadvantage in terms of quality of life symptoms or associated cost of care over 1 year in commencing treatment with first generation antipsychotics rather than atypical second generation antipsychotics in people with schizophrenia whose medication is being changed because of intolerance or inadequate response and who are treated in the context of pragmatic trial. So the limitations of the study were the proposed effect size of 5 point on the quality of life scale was unrealistically large. There was a limited sample size and statistical power. Quality of life is difficult to assess in schizophrenia, and insensitivity and imprecision of the quality of life scale would have reduced the power, although similarly in both the trial arms, and the patients had fairly long-term illness and the treatment effects were not large. This is my reference.
So I think this study has actually, they've gone against the norm of journal club. They were supposed to present journals which are released recently, recent trends. But deliberately, I put the study here because of it's a must-know study. One of the highly cited studies as a trainee in psychiatry. This is something which is mandatory to learn because this is very frequently asked in exams. You might have this as a short note. And the context is important because we all feel that newer antipsychotics are better in terms of efficacy or in terms of quality of life, they'll give a better quality of life. This study has shown otherwise the different results. So can you summarize what is the summary of the study?
Yes, so it was mainly how the first generation antipsychotic and the second generation antipsychotics, in the patients of schizophrenia, they measured the quality of life and the quality of life scale was used, and it was a 1 year in 1 year. And the assessment was done at 12 weeks, 26 weeks, and 52 weeks, and at the time the drug was given. So in first generation, various drugs were used, and in second generation, except clozapine, other drugs were used. Because clozapine versus the other second generation antipsychotic, the study is CUTLASS 2, which is the different study. In this study, they have mainly seen between first and second generation antipsychotic. And in quality of life scale, there was no much difference in between first generation, the people who were given first generation antipsychotic and the patients who were given second generation antipsychotic. In their scores, the mean score, there was not much difference. So, so to conclude everything, the study was not able to finally tell that whether the second generation antipsychotic are better, because in both the arms, both the patients who were receiving first generation and the patients who were receiving second generation, both of them, they were similar quality of life.
Understood. So any questions? You have understood everything, each and every slide, or you have any questions asked? Otherwise, I'll ask. But I think few switched into first equation. 10, 10, 21 to SGA 6. Here they can say it might wane, but I think whether they have compared how many people have switch जिन्होंने किया है groups में, whether they have compared.
No, sir, they haven't compared. They have just compared how many people died and
so they have not compared how many have switched. So whether it is not a limitation, it's a statistical limitation. Maybe they would have found it, but they didn't report it. Or you again go into the study and see. Dr. Asta has a valid point. Yes. Yes. And this is an issue because in June in Western population, first generation antipsychotics are also very costly. But in Indian context, first generation are not that costly. Second generation like cariprazine or lorazepam, they are very costly. But वहाँ पे पुराने की दवाइयाँ costly. That is why cost benefit analysis they are not found. This study is more applicable in their context, but not in our context as far as cost is concerned. I'm not a more risperidone or something because there is something known as DPCO. DPCO में जो दवाइयाँ जाती हैं, those are at par with the profit margins of those medications are taken off. Those are affordable. So risperidone is also maybe 1 milligram tablet will cost you 1 rupees in comparison with Alcadol. I'm not talking about the recent acts. This was a 2006 study. उस समय में उन्होंने कंपेयर किया, so this was found that no वहाँ पे ये बहुत था. Okay, so but this is not applicable in our context. It becomes a limitation of the study. Here's a point. Right?
Long acting were also included in that, but it was just the main comparison was between first and second generation. They have given injectables also. They have given in first generation and they have given.
क्या उन्होंने कुछ subgroup analysis किया
No sir.
कि long acting versus oral?
No sir. It was
with long acting and oral versus only long acting.
No sir. It was just between
Whether
first
is it,
and second.
is it not a limitation
generation.
that she is also a point. Dr. Gopal is a very good point. Then I think you should clap for Dr. for this point. But this is a fantastic point. And when you read subsequent papers who criticized Atlas 1, they have actually brought this point. Sulpiride is dominant drug in first generation. Once you read sulpiride is an atypical typical. It is not like you call risperidone a typical atypical. More closer to your first generation. Similar is the issue with sulpiride. So what they did was they actually skewed first generation group को उन्होंने sulpiride देके second generation से के साथ almost comparable. A huge limitation. ठीक है, good point. So ये तो सारे limitations आ गए देखो आपकी. फिर anyone else? Pragmatic बहुत जगह यूज हुआ हुआ है. पूछना चाहिए था. पूछा कि समझ में आ गया. मैं फर्स्ट ईयर को पूछा कि पक्का pragmatic मतलब क्या होता है? इनके इंक्लूजन क्राइटेरिया बताइए जरा. Inclusion criteria में schizophrenia, schizoaffective disease. But whatever conclusion they are deriving is, but this is a real life scenario. आपको schizophrenia real life में pure schizophrenia नहीं मिलेगा. So that is what, and age is a very broad age. This is a broad range age which they are given. And if you see exclusion criteria or substance misuse, medical disorders, बहुत ही highly stringent exclusion criteria भी नहीं. So my whole point is this is one of the examples of an pragmatic. Pragmatic is real life sacrifice. अगर ये substance misuse भी include कर लेते, so this would have been one of the perfect pragmatic real life settings with. Ultimately आप कितनी भी RCTs पढ़ लें, आपको real life settings में पेशेंट ठीक. So extrapolation नहीं आ पाता. Huge limitations of all the RCTs which we carry out. जितना आपका exclusion criteria stringent हो जाएगा, study might be good methodologically or statistically, but it might not be applicable for a real life setting. Patient आपको exclusion criteria लेके नहीं आता. So this is a question in exam. Name any one pragmatic trial. Atlas is a pragmatic trial. Can you tell me the full form of Atlas? यही पूछेंगे एग्जाम में, कटलास का फुल फॉर्म क्या है, आप बोलेंगे कटलास फुल फॉर्म क्या है, who was the author, and it is archives of,
Archives of Gender.
it's not archives,
Archives,
archives.
yes.
हाँ? अच्छा, एक वाइड कॉन्फिडेंस इंटरवल है ना, ये क्या होता है वाइड कॉन्फिडेंस, क्या होता है, तो व्हाट इज वाइड, एक जगह स्लाइड पे था ना, आपने बोला था, दिखाई, वाइड कॉन्फिडेंस इंटरवल, उसका मतलब क्या होता है, तो नहीं पता था, पूछना चाहिए था, एनीथिंग यू कैन आस्क, व्हाटएवर स्टैटिस्टिकली भी जो भी कंफ्यूजन आप पूछ सकते हो ना, एनकोवा क्या होता है, व्हाट इज आईटीटी, इंटेंशन टू
Intention
एनालिसिस,
to
होता
treat
क्या है, बेटा समझाओ सब,
the intention to.
ट्रीट एनालिसिस मतलब क्या होता है, डॉक्टर आयुषी सबको समझा रहे, ठीक है डॉक्टर आयुषी बता दीजिए। Just go back to the chart, the flow chart. बहुत सारी चीजें सीखने लायक है स्टडी में, सी जो भी रैंडमाइज हो गए 118 109 ऊपर हो गए ना, every follow up whatever patients are lost to follow up, they will still be included in the final analysis. It is not q 64 and 71 are included in the final analysis. If we are only including 64 and 71, तो जो डॉक्टर आस्था कहती हैं कि जी वो तो वहां चले गए वहां चले गए, so you are not actually doing justice, because then it will become a statistically poor study. This kind of an approach is known as per protocol analysis. But intention to treat analysis में है, एक बार randomize हो गए, एक observation आपने ले ली, then you can carry those observations subsequently. So actually में जो initially जो whole groups randomize हुए हैं वही analyze होंगे last में, नहीं कि एक भी observation को आप carry करके analysis समझ में आया, this is ITT analysis, this is more statistically superior analysis. Yes, overall, but they should have done a subgroup analysis कि कितने percentage patients switch किए and then why. They should have actually done that. They could have done. But actually में when we plan any study, आपके initial objective होते हैं, फिर आप उन्हीं को ही analysis, subgroup analysis, बाद में इस तरह की sensitive analysis, they are not considered ethical by some. But if you request them, they should. Maybe someone writes to them कि अच्छा हमें बताइए, they should have done. ठीक है, वाइड कॉन्फिडेंस इंटरवल क्या होता है, तो उसमें पता था कंप्यूटर मेडिसिन में क्या होता है, व्हाट इज 95% कॉन्फिडेंस इंटरवल, ये क्या होता है, तो 95% कॉन्फिडेंस इंटरवल मींस कि आई एम कॉन्फिडेंट 95% of the times my observation or my values will lie between this value to this. मेरा मीन वैल्यू 1 है, मेरा कॉन्फिडेंस इंटरवल इज -1 to 2, मेरा 95% कॉन्फिडेंस है कि ये इसी रेंज के बीच में है, and this is wider than usual, we call it wide confidence, so it's more heterogeneous, that is what, because they are themselves saying कि दोनों ग्रुप इतने heterogeneous है, एक तरफ सल्फिराइड का इतना skewed distribution.
Regarding
फेमस ट्रायल्स वाले प्रेजेंटेशन बता ना, आप ही ने तो
yes,
किया था,
yes, sir. Yes.
आप बताओ,
So Katlas
स्किज़ोफ्रेनिया के
1
और
was
फेमस
there,
ट्रायल्स
and
कौन कौन
so
से,
Katlas 2 was there, and ma'am, I'm going.
यूफेस्ट, सोहो,
Yes, sir,
ये
you
सब भी तो
first.
थे,
Yes.
एनी अदर क्वेश्चंस, हाउ दे रैंडमाइज्ड,
So randomized.
how randomization was done, how did they randomize the patients into two groups, उसका इन्होंने दिया हुआ है, दिखा है ना एलोकेशन,
It was via remote telephone service. undertaken after baseline assessment. Answer: the method of allocation was randomized per muted blocks within the study.
Whether randomization was done adequately or not, how can you comment? तरीका है कमेंट करने का कि अच्छा randomization हुआ. अब baseline values में वो difference आया था दोनों groups में. Go to the result section. Next. So whether there was any difference in these baseline values? Any statistical difference in दोनों baseline values में मिला था?
No.
अगर नहीं मिला तो that was randomized adequate.
Because in both the arms the values are.
Whether they compared it, उन्होंने compare तो किया ही होगा. If it's an RCT, they have to compare it. And ऐसा है तो फिर see, you can see number of difference 47 and 37. Both the arms. I think with this, it is an important study to learn. Remember, ITT analysis क्या होता है, performance analysis क्या होता है. This is very important. Pragmatic trial and example. This, I think, this much if you take it from this journal, it will be fine. So I think finally, as comments. Yushi. Supposed to comment, contribute. Dr. Rupali, or take presentation. But Dr. Mankar was pointing out that we are now giving second generation antiseptic. But if you go and see people who are practicing and the real life prescriptions, I think that it is the divide will be equal. People are still using typical first generation. And ideally, though, this differentiation should be taken off. So first generation and second generation, the dichotomy should be resolved because risperidone is more of first generation. So I think this is important. You take on presentation. ये जिस गाइडलाइन में से लिखा है, कैन यू मेक अ समरी? टेल अस. ठीक है, कितने कितने गाइडलाइंस हैं स्किज़ोफ्रेनिया में? Federation of Social and Biological Psychiatry, right? Nice guidelines of UK, APA, American Psychiatric Association guidelines, then British Association of Psychopharmacological guidelines, Indian Psychiatric Society guidelines, Texas guidelines, Port guidelines, so very famous guidelines. Port guidelines, which are it's not been revised, it's a very reputed guidelines. Australian, New Zealand journals, Australasian psychiatry, Ranzat guidelines, Mosley guidelines. इन सबका समरी बना के मुझे बताना है किसने ऐसा प्रेफरेंस बोल दिया, कमिट कर दिया है कि देना है तो फर्स्ट जनरेशन. You might be surprised. Many have not commented. It's an individual case scenario. आप एक बार समरी बना के बताओ. ठीक, thank you. I think it's presented well. It's a difficult, it's a large study and a presentation, but can be more clearer. You can be more crisp, concise. The slides should be more catchy. Alphabetical, the font size can be a little bit more irrelevant. Events you can take off. Best thing is you record a presentation, listen your presentation by yourself, and then you will feel that this is somewhere I am not getting the thrust while I'm watching myself. So how the audience will have. Thanks.